Hello everyone, my name is Cristina Polidori. I work at the Department 2 of Internal Medicine of the University Hospital of Cologne, where I lead the aging clinical research. And today we are here to talk about the importance of the comprehensive geriatric assessment in the aging population. So basically, and I'm very grateful to the Onco-Aging and EUniWell program, which were able to support this initiative. The old story goes back to the fact that our aging population is dramatically increasing. As you can see here from this slide, on the left-hand side, you can see that the population, the number and the percentage of the older population is dramatically increasing in the last years. And in fact, as far as Europe goes, we are experiencing, and we will experience, of course, in the next few years, a 2.5-fold increase of the population of 80 years old persons. And this goes also together with the fact that the increase of this older population does mean that it is important to improve clinical decision making in this population. And to improve clinical decision making, we have to think about the concept of prognosis. And as you can see here on this slide, on the upper part of the slide, for a 75 years old woman, it is possible to live 10 more years without disability. So this is really important because life expectancy is still increasing over time. And as you can see in the lower part of this slide, basically worldwide, the average remaining life expectancy during the course of the life is also increasing. So at every time we have to decide, even by aging and older persons, what is their prognosis in order to see and to take clinical decisions, of course shared. And here you see also in another similar way the fact that the life expectancy at birth is increased enormously during the past few years, as you can see here, steadily from 1840, and it will keep increasing up to 2040. But actually the disability-free life expectancy is not decreasing. So we have a problem in closing this gap between healthcare initiatives that can help decreasing disability with advanced age and this dramatic increase in life expectancy. So we have to think about moving the paradigm and shifting the paradigm from from lifespan to health span. So from survival and mortality as endpoints to survival in good quality of life and without disability. So if you look at this and try to see as the mission of geriatric oncology to compress morbidity, improve quality of life and well-being, and also decreasing disability-related outcomes, then we have to think about another important gap in geriatric medicine and in medicine in general. It's called the no-do gap. We all know that aging is a multifactorial process which bases upon the hallmarks of aging, which are very well known, but also on many other mechanisms that are in the process of being described. We all know that aging is an heterogeneous process, but actually we don't include in the clinics this fact of multifactoriality and also of heterogeneity of the aging process. So if we think about the traditional paradigm in which diseases by younger people can be treated because they are based upon a mechanism, often upon one cause, one mechanism, and therefore they can be treated with one therapy or with one drug or an intervention. Then with advancing age, due to this multifactoriality of aging and also due to the heterogeneity of aging, we should give an multidimensional approach to our patients, because for the prognosis of their cancer disease and also from the point of view of the success of the interventions, not only the disease will be playing a role and the severity of the disease, but also it will play a role their functions, their psychodynamic, their social factors and aspects, their, of course, comorbidities and polypharmacies, so other drugs that they are taking and other diseases that they are suffering from, but also the biological aging process per se will play a big role in the success of the diseases. So the biological age is strongly influenced by the decrease in organ function, which occurs in a continuum during aging and can be defined in aging medicine as the so-called frailty, like a state of decreased reserve capacity and increased vulnerability to stressors, also as a consequence of age-related degeneration of several system organs, and of course as a consequence of cancer. And there is a way to measure this multidimensionality also of frailty as a surrogate marker of biological age in medicine, which is the comprehensive geriatric assessment. The comprehensive geriatric assessment was first described in the 1880 years of the last century by Lawrence Rubinstein and describes at the same time diagnostic and also therapeutic instrument which evaluates not only the physical aspects, so the clinical aspects, but also the psychosocial aspects and the functional aspects of the aging person. And it produces an idea overall of the functioning status of the person in a way that an integrated treatment plan can be, and multi-domain of course, can be established and also shared with colleagues, with the patients, and with their caregivers. This is a kind of co-management that enables the comprehensive geriatric assessment. So this is also very important, this co-managing option and initiative of Onco-Aging here. The good thing about the comprehensive geriatric assessment and the possibility to detect or identify frailty and the level of frailty through the comprehensive geriatric assessment is that it is possible. We know today that frailty, so the robustness, the opposite of the robustness, can be led back to pre-frailty and robustness by individualized and tailored interventions, which are also multi-domain, tailored to the patient. And this multidimensional approach and interventions are can enable the amelioration of the frailty status because the frailty itself is a dynamic process. So on one hand, we know that frailty occurs in a continuum, and if we do not detect frailty as a surrogate marker of biological age, and also we do not detect these comorbidities and these different domains, problem in these domains of our patients, but for above all their multidimensional resources, if we know that if we don't catch this frailty, multidimensional status, then the frailty will occur in a continuum and lead to disability. If we catch the frailty status because we improve diagnosis, then we will be able to reverse the frailty status back to pre-frailty and pre-frailty, possibly to be restored to robustness. So this is actually at the end the very meaning of conducting the comprehensive geriatric assessment, having this checklist of assessments and measures that have to be adapted into your patients, and not just having them as a checklist of tests to conduct. And share your information together with the oncologist and also with the general practitioner, with the caregivers, with the patients above all. And then the trajectories of your cancer older patients will be kept under control much better, and quality of life will be able to be maintained. So I would like to conclude by saying that the comprehensive geriatric assessment is a very complex assessment, which can be at best conducted together with geriatricians and in co-management, and that it has also very much smaller screenings opportunities, which are also multi-domain and can help you in your clinical routine. Now I will give the floor to Dr. Valentin Goede, which is a specialist of onco-geriatrics and will tell us more about the importance of the comprehensive geriatric assessment in cancer in advanced age. Thank you very much.
Hello, my name is Valentin Goede. I'm a dual-trained hemato-oncologist and geriatrician, and I'm running the department of Onco-Geriatrics in the St. Marien-Hospital here in Cologne. This institution is closely collaborating with the University of Cologne. From a clinical point of view, it is very important to assess the biological age of older cancer patients, and I would like to provide you with 5 specific reasons why to perform a geriatric assessment as our current standard assessment method to capture the biological age of patients in older cancer patients. So the first reason to perform a GA in those patients is that it allows to detect aging-related health issues that otherwise might be unrecognized during a normal oncological workup. It has been shown, for example, that in patients who have been labeled by their oncologist to have a very good performance status, that in these patients, if you perform a geriatric assessment, then some issues might become evident, like, for example, fall risk or cognitive deficits. And of course, these primarily undetected issues might be of very great importance during the further course of cancer and its treatment. So think of cognitive problems and adherence problems later on during cancer medication, for example. The second reason why to perform specifically a geriatric assessment in older cancer patients is that it allows for a better prediction of overall survival. In some cancer entities, there have been new scores that do not just incorporate cancer-specific factors that impact on overall survival, but also aging-related factors as assessed by geriatric assessment. This is not true for every cancer entity, but for some, like, for example, aggressive lymphoma or multiple myeloma. And probably other cancer entities will follow. Now, it is also important that the geriatric assessment may allow to better estimate cancer-unspecific remaining life expectancy. And this might be very important when there is the decision whether to still treat a very old patient or not. A third cause to perform geriatric assessment in older cancer patients is that it allows for better prediction of chemotherapy toxicity. And in fact, there have been calculators developed based on geriatric assessment that allow for a better prediction of those adverse events during chemotherapy than, for example, simply by the estimation of the clinical performance status of the patient. These calculators are, for example, the CARC calculator or the CRASH calculator. And all these calculators are available online, free. So as a treating oncologist, one can assess them and then calculate the risk of toxicity in % during the chemotherapy. This is very important to give good advice to an older and maybe frail cancer patients, how to treat and with what chemotherapy. The fourth reason why to perform a geriatric assessment in these older cancer patients is that if you do so in a substantial number of patients, the initial oncological treatment plan will change or will be refined. This has been shown by several studies. For example, there has been a recent systematic review on those studies, and it has been demonstrated that in about 30% of the patients, the treatment plan will be changed, either towards a reduction of the intensity of the treatment or even an escalation of the intensity, depending on the geriatric assessment results. So, geriatric assessment is important to really optimize your oncological treatment plan. And finally, the fifth reason why to perform geriatric assessment in older cancer patients. Well, this is that it has been now shown that when we use these assessment results and then initiate tailored geriatric interventions to address the frailties that had become evident by geriatric assessment, then it is possible to reduce the toxicity of chemotherapy during further treatment, so to improve the tolerability and also the feasibility of chemotherapy in older cancer patients. This has now been shown by several very large randomized clinical trials. These have been published very recently, and these data makes it really imperative actually to perform a geriatric assessment prior to the beginning of a new systemic treatment of older cancer patients. And probably these data will change current guidelines very soon. So another question is how to perform this geriatric assessment, which geriatric assessment tools should be used. And this is not as clear as the reasons why to perform a geriatric assessment. But the general recommendation is to start with a geriatric screening. There are several tools that are propagated to be used specifically in older cancer patients, like, for example, AG8 screening or something like this. And then, depending on whether the result is abnormal or normal, maybe proceed with a geriatric assessment. So this might help to spare some resources. Actually, if you start your clinical career now and you look into oncological management of older cancer patients, you barely might see geriatric assessment done in institutions that take care for these patients. And this is simply due to two reasons at the moment. One is lack of knowledge, but I've provided you with the knowledge now. The other one is a lack of resources, because performing a geriatric assessment and then maybe also tailoring and realizing subsequent geriatric interventions, this is a huge task, a very complex maneuver, and this takes resources that are currently sometimes not reflected in available budgets. But at the end, the scientific evidence probably will rule, and therefore we can expect more geriatric assessment activity in older cancer patients very soon. I thank you for your attention. Goodbye.